Thomas Hill, once again here, sharing with you as I often do. And the special thing about today is that we get a chance to talk to the founder of MTM Services. And why I'm so excited is because this young man, I've had the pleasure of meeting his two sons. And a lot of times, you can tell a lot about people about the character of their sons, especially in a man. You see his character, you see his kindness, see his gentleness, you see his desire to help others. All of that had to come from a source point. And we realized that source point is coming from David Lloyd Sr., who is the founder of MTM Services. And David, I'm so excited to have this opportunity to speak with you on today.
Thank you so much, Thomas, and thank you so much for all the work you've done with MTM team and bringing the information about what we are trying to do in helping behavioral health and community health centers. But I really appreciate your dedication and your professionalism. So it's a pleasure to be with you and look forward to our conversation.
Now, I'm not even going to waste any time. I want to talk about the very beginning. What was the motivation that it just fueled you to start this company?
Thomas, I've been in a very long 25-year career with a multinational corporation. We were franchisor and I was their CEO for 13 years. But in 1991, about 2 years before my retirement, I was appointed by the county commissioners here in North Carolina to serve on the Behavioral Health Center board. And when Commissioner King called me and said, David, I want you to serve, he said, we've really got a challenge over there. We've got a lot of people who need behavioral health services, alcohol, drug, developmental disabilities, and mental health services. He said, but we can't get people in. He said, it's just they're overwhelmed. And the state of North Carolina has changed our funding from a grant. In those days, the nonprofit behavioral health and community health centers received a grant, basically a budget, and you got a check 1/12 at the beginning of every month. And basically, if you saw 100 clients or if you saw 1,000 clients, you got the same amount of money from the funding, federal and state.
Right.
And so he said in 1990, the funding changed to fee for service. And that means you have to see clients, you have to deliver a service, and you have to file a claim. You have to file a bill, if you will, or an invoice with the state and with the federal government, and then you get paid. And he said they just cannot get enough money coming in to support them. And the county has given them millions more, but that's not enough. He said, can you serve on the board? And Thomas, it was really interesting because I agreed to, and in February of 91, I went to my first board meeting, knowing, because I'd been in business for, again, 23 years at that point,
Right.
knowing that there are costs and there are revenues, and you have to support an organization. You have to have certain awarenesses and data or measurement. And one of the things I knew they had to have is what was their cost of service for like an hour of therapy? What was their reimbursement rate? Also, how long was it taking people to get into care? And what was their no-show rate? Meaning if they were scheduling a lot of clients, but they weren't showing up, then we weren't collecting a fee. In the old days under grant, it didn't matter if they showed or not, we still got the same check.
Right.
And so at the board meeting, I asked a simple question. I said, what is your cost of service here for an hour of therapy? And the administrators present, and this was a 24-person board. This was at that time, an $18 million a year agency. And the finance officer said, well, that doesn't really matter because our costs may be high, but we're getting fees in. And it was basically just kind of a nonchalant answer. And I said, well, let me ask you another question. What is your no-show rate here at this center for individual therapy last month? And he said, they looked around, and finally the finance officer again said, it's much better than it used to be.
Wow.
I said, oh, okay, much better. I said, so what did it used to be? And he said, oh, much worse than it is now.
Wow.
And what I realized, Thomas, he didn't have a clue what
Wow.
their no-show rate was.
Wow.
So I started to really get interested on how, as a board member, I could get involved because I started to ask questions. How long are people waiting to get into treatment here? Not to get an appointment and answer questions, but to get to treatment. That's a whole different world.
Right.
If they come in and they're depressed, is it taking 2 weeks, 3 weeks? And so I made a motion that night. I said, as a new board member, I'd like for each department or program to tell me and the board next month how many people are waiting, what they're waiting for, what service are they waiting for, and how long have they been waiting. And Thomas, what I realized is this, the administrators had no idea. So I, as a committee chair, I was asked to serve as finance chair of the board.
Mm.
I got involved and I started to going into the center and asking questions. And what I realized is we had a very large facility, 378 clinical and administrative staff. But if you were a child or adolescent and you were depressed, it would take you 9 weeks to get
Wow.
to face to just for the first diagnostic interview.
Wow.
So what I realized is that this was not treatment. This was not service. If you wanted to see a psychiatrist in that center, and this is not unusual, this is not atypical,
Right.
it would be 3 to 4 months before you could see. So, what we were saying, Thomas, is thank you so much for coming to see us. We know you're depressed. And what we're going to do is ask you to hang in there for about 4 months, and we'll get you to our doctor so he can look at medication for you.
Mm.
And so, what I found is that there had to be a different way to deliver services. And so sitting in those board meetings, attending staff meeting, committee meetings, and so forth, I started to think, how could we do this differently? And in 1993, I'd been on the board for a couple of years. I retired from my first career and after 25 years. And I basically, there was a position open. And I really, Thomas, I fell in love with what we were doing to help people, trying to help people, but I
Right.
felt like
Right.
we could do it much better, more
Right.
efficiently, more effectively.
Right.
And so they had a deputy director position open. I applied for the job, and they hired me. And so for 3 years at that same center, I retired, resigned from the board, became a staff member. I started to study what we did, how long it took us to get from a person from first call for help into an interview for assessment, and then into treatment planning, and then to treatment. I've started to really measure movement of people, measure how many were coming per day, measure how many appointments our clinicians were carrying per day. I was looking at no-show rates. And what I realized at that center, we had a no-show rate of 62%. In other words, we'd schedule 100 people at the beginning of the day. At the end of the day, only 38 had shown up.
Wow. Wow.
While we were having people wait weeks to get
Mm.
to see a clinician. So I really got involved in trying to redevelop our service delivery process. And I came up with a model called accountable care. And accountable care has three characteristics. One, how are we best accountable to the clients, to the people that we're intended to serve? How quickly can we get them in? How can we give them good quality care? How can we show outcome wise that they're better and that their depression is better, whatever the needs are? How can we do that first with the client? Secondly, accountable care has a component of how can we be accountable to the staff serving those clients. And Thomas, my office location was at the back. This was an old hospital and that we had remodeled into a mental health center. It was a Y-shaped building. And I could sit there at my office and watch every staff member coming in and out because we had to enter through the back door.
Right.
And I watched staff leave at the end of the day totally exhausted. I mean, and a lot of times they would be taking a lot of files, particularly clinicians in those days before
Right.
HIPAA.
Right.
You could take files home and you could work on your charts, if you will.
Mm.
And I would watch people come in the morning exhausted. And I started to going around the center. I just would walk around each day and look at staff. And what I realized, Thomas, in the for-profit world, which I'd been in for 25 years,
Right.
if staff were at that level of fatigue, at that level of almost depressed, if you will, uh, we would be very concerned because those staff couldn't function very well.
Right.
And so what I realized is that we had a lot of people who needed care, which we couldn't get them in. We had a lot of dedicated staff who really wanted to deliver services, but what they were doing was very, very busy work they were not seeing clients. They were
Right.
very busy. We had a lot of
Right.
meetings. We had a lot of no-shows. We had a ton of paperwork. Right. In those days, it
Right.
wasn't computerized
Right.
back in 93. And
But
so I started to look at the processes. How could we reduce the workload of these clinicians? How could we reduce the paperwork? And so we started to look at the intake process and realize, in fact, I held a focus group. We had about 25 consumers or clients
right.
who came, and I just wanted to talk to them. And they'd never done that at the center. And I said, tell me, do you get good care here? And one person said, well, yeah, pretty good. He said, but if you ever get in, you can't ever get out. In other words, we would not discharge. So we
Wow.
just kept bringing people in, but we had no
Right.
room.
Right.
And then I said, what else? And he said, well, don't y'all own a copy machine? And I thought about it. In my first book in 1997, the chapter is entitled, Don't You Own a Copy Machine? And I said, yeah, we have a copy machine on every floor. He said, well, let me ask you a question. Why don't you, when you interview us and ask us all those questions about our past and our family and our medical, he said, why don't you just make a copy and pass it down? He said, because the next time I come in, the next staff asks me the same questions
Right.
over and
Right.
over and over.
Right. Right.
So I started to look at redundancy, and I formed a paperwork team, and we basically went at our paperwork from not from a this is a form and this is a form. It was
Right.
all vertically developed.
Right.
I wanted to look at it horizontally.
Right.
I wanted to look at if you came into our care and you gave us your name and your date of birth and you gave us pertinent information, why are we asking for that information again?
Right.
Why?
Makes sense. Makes sense.
Number one, it takes time, and it also is very concerning to our clients and almost annoying. I don't know if you've ever been in a doctor's office and you go in and
Oh,
they
yeah.
ask you a question, then you ask it.
Yeah.
Well, what I realized is we were just redundant out the gazoo. And so we started to change. We changed the forms, we changed the processes. When I got to this mental health center, we had 19 different types of diagnostic assessments. We had 27 different styles of treatment plans, and we had hundreds of
Mm.
progress notes.
Mm.
So if you came in for mental health need, but also had a substance use need, you had a totally different assessment, a totally different treatment plan, and the clinician was using totally different tools to record your services. So we couldn't even communicate with ourselves.
Wow.
So basically, I set out in that 3 years that I was with that center in trying to make these changes occur. I worked with clinicians on how to write less, not write more, because they were writing journals of notes, and they needed to write the right kind of note, but we had them just write and write and write and write. So we worked on that. We worked on so many things, the intake process, how many times they would have to answer the questions. And so after about 2.5 years, our services had really improved. We were getting people into care. And I was asked by the National North Carolina Council for Community Behavioral Health Programs at their fall in 1995 to present a case study of what we had accomplished at this center, how we accomplished it, and what were our goals. And by the way, the third accountability, I mentioned there were three, is to the funder, to the state, to the federal government, to
Right.
the person paying the fee. We wanted
Absolutely.
to make sure we gave a good quality product at an affordable and best affordable price. So we looked at clients, the staff, and the funder. And so I presented that case study in October of that year. And out of that, David Swan, who's now on our team,
Hmm.
was a director of a behavioral health center here in North Carolina, up in Dobson and that area. And he said, would you come and talk to my staff? And that was the first, it was in the fall of 95, was the first opportunity I'd had to go and visit other staff.
Right.
So I started visiting these centers, and one by one in the North Carolina, people asked, other directors had heard about, what I was doing with David, and they wanted me to come and basically work with them on this accountable care model. And so in effect, in 1996, in January, I retired from the Behavioral Health Center and I started MTM Services. And the MTM I came up with that from management, training, and measurement. I wanted to look at those three things because what I realized is we needed managers and leaders in our centers. And what we had were people who really were beautifully and wonderfully clinically trained, but who did not have any basic business experience or management of business experience. such as working with data, working with dollars. If your cost of services is $200 and you're getting 100, you've got to do something about that. And those kinds of dynamics in a for-profit setting just weren't there in the old grant days of the
Right.
of the funding for the public centers. So in effect, I started to work with different centers in North Carolina, and then I was using sick leave days to go up there to visit with each
Right.
center,
Okay.
and I realized that wasn't going to work. So I started management, training, and measurement services. That's a long name, Thomas. So we
Yeah.
shortened it. The first time I printed it
Yes.
on letterhead, it was like across the whole page. And I thought, that's a long name. So we shortened it to MTM Services very quickly, by the way, after we started the company. When I printed the stationery, I realized I had overdone the words there. So in effect, I started to visit with different centers, went out in January of 96 as an MTM consultant. I was the only one. I was the receptionist. I was the invoicer. I
Right.
was the person who wrote the checks. I paid the bills. I did it all. I was a one person show.
Right. Right.
and uh, and then I went to one of the consultants. One of the teams I was working with
Right.
was working with the National Council for Mental Wellbeing,
Yes.
headquartered in Washington D.C. and
Okay.
they represent all the behavioral health centers in North America, and they were making comment about some of my work, and so in effect, they asked me to come and talk with them about what I was doing with this accountable care model, and so I did. And in that conversation with them, the director of the Alabama behavioral health system was there, and he said, "Why don't you come down to Alabama and help us?" And so I did that, and then the National Council asked me to write a book. I would be willing to document the accountable care model. What were the elements of it? How do you go from where you are to implementing this new model? How can we make that happen?
Right.
And so my first book, How to Maximize Service Capacities, I published through the National Council for Mental Wellbeing in 1997.
Outstanding.
My second book was an improvement of that book. In fact, I'm going to hold it up because I call this 680 pages of easy reading at night. This book, Thomas, if you want to go to sleep, this is a great book for you because it goes into detail after detail after detail of what is the accountable care model. And not only did we talk about it, we actually tried to create a documentation path where if you were a mental health center and you wanted to find out more about accountable care, you could get that book and look at it. And we broke it down into specific steps. Start here you go next, and next, and next. And so what has happened over the years, after about 1997, 98, I got very, very busy because the council, National Council, wanted me to present at their national convention. And so there I'm presenting to all behavioral health centers per se in America.
Right.
And out of that came a demand or a request that I travel. And so I started to work. And at this point, I've worked in 47 states, and we've worked with over 900 behavioral health centers and community health centers.
That's
And
outstanding.
we've gone through those. And then I realized I needed some help. So I started to recruit other consultants like David Swan on our team, Michael Floor on our team.
Yeah.
These are directors I work with, but I was so impressed. My son Scott, I wanted to give him some employment while he finished his college education, and he fell in love with it. And he's now president of the company.
Right.
And I officially retired in late December 2018 after 52 years of active work.
Wow.
But I must say, watching people, and how can I say this, Tom? To watch staff who come to work exhausted, to watch them change and to become energized again and excited about their work. That's what the reward is for me. To watch clients, because one of the programs we have is same day access. If you call us today, you can get in today. And we work with hundreds of centers to convert from weeks of wait to, if you call us today, we'll get you in today. That model is called same day access. Scott and Joy Fruth are the ones who really work on same day access. Same thing with psychiatrists. We call it just in time psychiatry, 3 days to get to a psychiatrist, not 3 months.
Wow.
So we've watched all of these things change to benefit the client and also to reduce the redundant workload of the clinicians so that they don't retire or retire early exhausted. But that's kind of how it got started. I fell in love with it. But then the real question was, could I take for-profit business principles, which I had been schooled in for 25 years,
Right, right,
could I take that and bring it into a clinical setting with nonprofit type organizations,
right,
and would it work? And
right.
that's why the accountable care model is a bridge between those two worlds: accountability into quality of care and outcomes, such as, again, with Andy Jensen, with the DLA 20, and
Right.
the work we've done there with Willa Permanez, who's the creator of that instrument. But that's kind of how it's evolved. Somebody's asked me several times, I've been asked, well, how did you come up with this business plan? And Thomas, the answer is I didn't have a business plan. The
Wow.
catalyst, I believed, was that if I got up every day and tried to help tried to help the clients who desperately needed our services, and tried to help the staff who were absolutely working themselves to death, really.
Mm.
And if I could be accountable to the funders and to the governmental agencies, that we would have done a good job. And that was the motivation. And out of that motivation came this expansion that was certainly not planned.
Yeah.
It was
And,
just,
and
my
you know,
dad used to say, son, if you get up every day and do a hard day and honest day's work, there will always be people who will want you to do work with them. And that's
exactly.
been the motto. And that's kind of how we've done it.
And the funniest thing about all of what we're sharing and what you've been sharing with me is I had a list of questions. I had a list of questions that I was going to ask you. And believe it or not, you answered each one with the exception of two of them. And
Okay.
sharing where how this all got started. The thing that I love the most about this is when I look at how you're able to integrate the different tools, you understood the mathematics across the board,
Right.
that certain things were not getting accomplished. There was something lacking here. There was something need to be added here. And
Mhm.
to get that balance, where did you realize these tools? Because I noticed you shared various instances where how it was effective and how you saw the changes. But when did it really hit you that this is really what has been missing?
To what was missing in the measurement process. I guess the first was there were two elements I was concerned about: wait times. So that's a measurement. It's a data point. Call
Right,
for help. And so what we had to start doing is I realized we didn't have any metrics or any, how can I say, mechanisms or processes to even measure that. So if you called today, Thomas, and said, I need help, no one was logging that
right,
to then say, how long did it take us to get Thomas into care?
right,
Nobody was logging the second.
right,
So what we had to do is effectively set up metrics of measurement points. How do we measure these processes? Because they weren't being measured. Because under grant funding, remember, it was important, but it wasn't important. It wasn't critical to your survival financially.
right.
I think the other part, though, was staff fatigue, staff burnout. I was very, very concerned about how many hours staff were spending documenting services that we were delivering. So I started to actually ask the staff, and this was not popular. I want to
Right. Of
say this,
course.
but I asked them to fill out kind of a daily item for me. When do they start work? When do they end? How many hours of service they delivered? How many hours did they schedule? How many no-shows did they have, and how many hours they spent documenting services. And
Okay.
I just took those and put them in old Excel. In fact, it was Lotus 123 in those days. But I put it into Lotus and started to doing just little trends. And what I would see is some staff were spending enormous amount of time writing, documenting the services. So we then started to look at the form model. We started to look at what we were training them to do. And candidly, at that time, if you were getting your MSW, Masters in Social Work, the genre or the mantra was, if you have any question, write more. The more you write, the better. And
Right,
what we had to help them understand, it wasn't how much more, but what they should be writing
right,
is what we
right.
needed. So we started to define what they should be writing, tied to Medicaid audits and other audits here in North Carolina. But I think that my awareness was that we really didn't have any capacity to understand how long it was taking and what the staff were really doing. All we knew is they were busy.
Right.
What I tried to define in metric terms is what were they busy doing? And that's where I think my light came on. It was like, wow, if we could understand this and why are these staff spending so much time writing? And if we could take that and convert it to actually seeing clients, it was like the light bulb came on, Thomas.
Outstanding. Outstanding. When you reflect back, because when I look at MTM services, one of the things that Scott shared with me was, first of all, the book that you wrote, and it was kind of comical to me when you were sharing about making copies of various forms,
Yeah,
but you were speaking into existence how more efficient we needed to become in addressing those mental health concerns, and of course drugs, whatever the case may be, whatever kind of conditions that are being addressed in that particular situation. When you look back, just I mean, because I'm sure that there's certain points where you knew it was a turning point. Where were some of the biggest breakthroughs when you began to get this information, put it together, and utilize it and leverage it and see the results of it? What were some of the breakthroughs that you remember that really kind of stand out uh, when you look back at the very beginning of MTM services?
absolutely. I think there were two that really stand out in my mind. The first in our child adolescent program, uh, if you called us today with a child or adolescent and you were the parent guardian and you needed help, what we would say to you is it's going to be 9 weeks before we can actually see you. And so, what I thought about, and I had two children, I had two sons, and
Right, right,
Thomas, I thought, if this was my son, if this
mhm,
was one of my children,
right,
and I called an agency and said, my child is depressed, whatever the issues are, I need some help. And they say, well, hang in there for 9 weeks and we'll try to get you in. I thought that was deplorable. And I thought it was unethical. And I thought it was not good care. And so when we were able to move from 9 weeks to the same week or within 3 days, and then we
oh yeah,
moved into same day modeling. But when we're able to do that and see these children come in and actually get help, that was a real turning point for me because it was like I got excited. The second one, when I got to the center, our staff, because they were performing very low in terms of direct service, and now we were only getting paid for what we delivered,
right,
there was no money.
right,
And our staff, when I got there as deputy director, had not received any pay increase or benefit increase in 4 years.
wow,
And basically, what we had happen is staff were having to leave and go get jobs elsewhere because they couldn't continue without some type of cost of living increase.
right,
So what I said to them, I said, if we can change this process, staff, if we can make sure that you're actually seeing clients and they're actually showing up and you're actually delivering the care and documenting it, those fees coming in will allow us to give you salary increases and benefit increases. That's the only way we're going to get it. And you know what, Thomas? The staff and the managers believe that. So at the end of the first year, we gave every staff member in that center a 11.9% increase in pay.
that's
Now,
huge.
they hadn't had
That's
one
huge.
in 4 years.
Wow.
But what I saw, candidly, were that staff were again, we had to make up for a lot of room, but we compensated them out of their work, but we helped them to refocus their work and actually seeing clients instead of being busy or staying busy. So I think those two for me was like, wow, this might work. I mean, this could be very good for the staff. It could be very good for the clients and families, but it also would be good and fair to the funders.
As we conclude this interview, one of the things that I was able to connect with all of the staff at MTM Services is their desire to serve
Mhm,
and their desire to help,
mhm.
their desire to empower, and Scott leads that. Um, but one of the other things that I thought that was very unique, everybody understood the work. It was like, okay, this is my assignment. Annie has one, Samantha has one, Charlie has one, Scott has one, David has one, but everybody is still unified. It's like a well-oiled machine. So, with that being said, where do you go from here, uh, David? I mean, because what you have come up with has revolutionized this industry, had made it more accountable. as far as saying, okay, this is what we do, and this is why we do it, and this is how we want to make it better. And you guys have proven that. So when you get to a point like this, you've seen some changes. Where do you go from here?
I think, I want to come back just to a comment you made. I appreciate your comment about the team members all having a common purpose to be of service. And I must say that's how we've recruited team members. And that's why it's almost like you have to have belief that this change is needed and this change will be helpful. And if you believe that, then let's get in there and let's get it done. And each staff has been given a part of the accountable care model. As I said, when I started, it was kind of like a one person show, but we needed more specialization and we needed people with specific skill sets. And that's why how we built the team. I think where does this go? Your ultimate question is that I really think that we have a lot of work yet to do because the key thing about our service delivery system is our funders and our governmental agencies keep changing kind of the ground rules. They keep changing standards. They keep changing processes. For instance, in the community behavioral health, we now have certified community behavioral health centers or clinics, CCBHCs as we call them. That's a whole nother world of integrating physical health into behavioral health and treating the whole person, not just the substance use or the mental health, but also looking at their weight, looking at their blood sugar. We're trying to find how do we treat the whole person. And so what I see as exciting is that we now are bringing these concepts of accountable care into primary care as well as to behavioral, and we're integrating it into saying how can we help this person. And I think that's our future. I think that's where we're going is, and we're moving more and more. In fact, a lot of our work today is with these certified community behavioral health clinics, which are integrating physical health as well as behavioral and learning how we can change those systems as well. So, I'm very excited. I think we've only scratched the surface, so to speak, but I really am appreciative of the team and what they're doing, and appreciative of all the centers that have welcomed us into their campus and to really let us look at what they're doing and be responsive to the recommendations that we made and to follow and watch the outcomes are just fascinating to see these centers change and the staff and the clients.
The thing of it is that I've enjoyed this conversation, this chat that we've had, mainly because it has given me a real look at mental health. I think mental health, and I think some of the other things that happen in life that people are challenged by, a lot of times, and I've heard this, and it's so interesting to me, is because the information you've shared here tells me how much and how stagnated it has been, why it's been very difficult, and why we see so many people facing that in so many different institutions, whether it be in prison, whether it be, as you said, medical care. And so to be able to properly assess those things and have the right tools to do that and the metrics to track it, it just really is good to see all of this technology and all of this knowledge being used to help others on a different platform. A lot of times people don't really necessarily understand the different nuances that go into making something work the right way. And I think a lot of times we don't take the time, we don't sit down, we don't have the patience to try to look at it from a different perspective, how it can be more effective, but also serve each particular function within overall getting the goal accomplished. And I think that's what you've done. I think you've set us in the right direction. Prayerfully, a lot of folks will adapt this model and begin to understand the power of it. And really, at the end of the day, it's about serving people,
Yes, it is. Yes, it is.
serving people in a timely fashion. In a timely fashion. Thank you so much, David Lloyd Sr., founder of MTM Services. I tell you, I've really enjoyed this conversation. And I tell you, once again, I want to thank those that are listening and those that are viewing right now. But most of all, if you get an opportunity, go back and look at this again because you really need to understand the magnitude of the timing in which we're living in right now. A lot of the things we're missing out on, and a lot of times we look at things that happened maybe 10, 12 years ago about trying to get served in a particular capacity, going into a center, getting some mental health or drug abuse or whatever the case may be. And it's that period of time has been long. And thanks to David sharing with us on today, that wait time is not as long as it used to be. And we thank you so much for sharing this with us. Of course, I've got to have another conversation with you because there's a lot of stuff that I want to talk to you about and some other things that are really I think is important. But right now, today, we're just going to put a period. Well, as a matter of fact, let me take that back. We're going to put a comma right here. And we're going to
Okay.
stop it right here. But I look forward to talking to you again. Once again, David Lloyd, Senior Founder of MTM Services. Thank you so much, David, for your time.
Oh, certainly, Thomas, and thank you. Thank you for your time and your professional approach to this. I really appreciate your bringing this message to other people. Thank you very much. It's been a
Thank you, sir.
pleasure.
Thank you so much, David.